In the phase 1-2 studies, we have observed that 5 patients, or 11% of the total cohort, experienced severe adverse events immediately after ruxolitinib stop, including fever, uncontrolled splenomegaly, and shock. And subsequently, we observed other clinical cases of severe adverse events in patients receiving ruxolitinib as a bridge to transplantation. This phenomenon was called ruxolitinib discontinuation syndrome and seems to be caused by an acute and massive release of pro-inflammatory cytokines at the stop of ruxolitinib. In 2016, we started to collect clinical and laboratory data for patients who received ruxolitinib outside of clinical trials, so in real life. This network now includes over 700 patients, and 251 have discontinued ruxolitinib after a median time of 3 years. Here we wanted to understand the incidence and severity of RDRs, describe the modalities of drug discontinuation in real life, and investigate risk factors associated with ruxolitinib discontinuation syndrome. The first observation is that around 14% of the patients may experience a mild to severe RDS. Severe RDS seems to be quite rare because it occurred only in 3 patients, and it is a very early event because it presents within 48 to 72 hours from ruxolitinib discontinuation. Mild and moderate RDS are less early events than severe RDS because they occur after a median time of 7 to 10 days, and their main clinical manifestation is a spleen flare, a symptomatic increase in the spleen size, but also recently observed in the phase 2 study of the KRT-MDM2 inhibitors. The second observation is only 35% of the patients stopped ruxolitinib after a period of tapering, and also the tapering was very variable in terms of modality and duration. Probably due to this variability, we could not detect any positive association between the use of tapering and the decrease of a discontinuation syndrome, and possibly the implementation in the future of discontinuation strategies may allow better control of this clinical problem. Finally, we have observed that the patient with a more severe burden of a disease, particularly large splenomegaly and thrombocytopenia, are at higher risk for ruxolitinib discontinuation syndrome. And these patients are those that are more likely to stop ruxolitinib and enter into a clinical trial. So this is a very, very important setting to be explored. So in my practice, I try to reduce the risk of RDS in 2 ways. First, I start any other therapy immediately after ruxolitinib discontinuations, or perhaps even with a brief therapeutic overlap, as already observed and suggested in the transplant setting. Particularly in the patient with a large splenomegaly or a great burden of the disease, I try to prescribe prophylactic corticosteroids and or hydroxyurea. Very importantly, I consider at risk for RDS all the patients, regardless of ruxolitinib dose, because we observe discontinuation syndromes also in patients that were treated with a very low ruxolitinib doses. If I observed an acute clinical deterioration immediately after ruxolitinib stop, I will formulate the working hypothesis of the discontinuation syndrome, and I will probably suggest to rechallenge the drug. If I observe a symptomatic increase in the spleen length, this spleen flare may indicate residual disease control activity and may identify the patient who could still benefit from a second-line JAK2 inhibition. So, in these cases, I would consider a ruxolitinib rechallenge or the use of a second-generation JAK2 inhibitor.